Hi, I'm Dr. Don Murphy. I've been practicing geriatrics in the Denver area for the last 20 years, worked with Senior Care Colorado IPC.
And my name is Mark Grimm. I'm a licensed clinical social worker, specialist in geropsychiatry, also interested in collaborating with primary care and psychiatry.
Just want to point out that in our practice, Senior Care Colorado IPC, we have the luxury of working with someone like Mark and his colleagues in this area. But today we also want to address how you practitioners who may not have access to such resources can cover these topics on your own.
Today our agenda will include the issues of how to address the challenge presented to providers in relationship to the death and dying issues, how to engage in having a talk with patients and families about that. We're also going to take a look at attitudes related to grieving, medical interventions available to the provider, as well as tools and resources, and last but not least, reimbursement for counseling patients and families. I find that people have an incredible ability to deny that people are going to die, and so we need to help them understand that death is a normal part of the life process. We're born, we live, we exit, we die. And so the best solution to all of this is to have these discussions on a regular, ongoing basis with patients and families as their medical condition changes.
And I would like to thank our new Grim Reaper for putting that out there for us. I do want to note that there are a number of challenges that we providers are faced with when dealing with these issues. One is that it's easy to overlook this, or at least put it off, because we're always dealing with a number of other medical issues. Second is that often the patients, families, providers might feel uncomfortable having these discussions, particularly if they don't have a lot of experience with it. But for the most part, you do not need to feel that discomfort. People actually welcome that. Third is family dynamics can be complicated, and it's most important to have these discussions when you sense that there could be disagreement among the family members. When there's full agreement, it's easy. Next is we do have to make time for this, because this is something that we could cover in 2 or 3 minutes. It's something that could take a half an hour or longer, and we as the providers have to figure out how to parse that out over either one visit, multiple visits, whatever. And then finally, we want to make sure that the providers know that there is a good way of getting reimbursed for this type of counseling.
Step one in addressing the dying and end-of-life issues has to do with examining attitudes, and that's not only our attitudes as practitioners, but those of the family. I think most physicians, it's safe to say, are focused and committed to curing disease and maintaining people's health. And when we get into the later stages of life, people are now at a point where they no longer are going to have a cure. And so physicians, I find, have a difficult time making that transition of helping people die versus helping people to live. Also, I think that one thing that providers fall into the trap of is treating a disease process. And I think the transition that we need to make there in working with the dying patient is that we're now treating a human being. And that's a subtle but nonetheless very important distinction. Then also with the family members and the patient, we need to pay attention to their culture, their ethnicity, because those drive attitudes as well. Obviously, the Hispanic community, the Asian Pacific community, the African American community, all have different views on death and dying, and we need to be tuned into that so that we can do the best job possible. As I work with patients, I think sometimes those of us who are providers are afraid that if we provide them with certain specific pieces of information, we will take away their hope. And we don't want to take away people's hope. But on the other hand, people want us to be honest. And I'm almost a little reluctant sometimes to give people the cold hard facts, but after I do that, they thank me profusely for being courageous enough to tell them, because they really do want to know what's going on. In order to be effective in this area, we have to first of all develop a good therapeutic relationship with the patient and the family. Otherwise, they will not be able to hear what we have to say to them. One of the mistakes that I notice that many practitioners make is that we use a lot of technical terms, and we have to translate that into layman's language so that they can really get a grasp of what's happening. And so what I always advise people to do is to kind of take this tact to say to patients, here's what you can expect is going to happen. There is no cure for your particular condition. It's going to get worse. And what we want to try to do here is manage your symptoms and keep you as comfortable as possible with the highest quality of life. And in order for us to understand what you want, we need to have this talk.
And I would add, Mark, that as you point out, we do need to cover this, but oftentimes it's in teams.
Yes.
That, for example, if I, the doc, don't do it, you can, a PA and MP can do it, perhaps even the specialist, an oncologist taking care of it, but somehow we have to assure that it's happened.
Yeah, and I would also add to that, one of the first rules of communication is repetition of the message. And we need to oftentimes come back and repeat this information for folks because they kind of absorb it in bite-sized pieces.
Right.
Another thing I think we need to keep in mind is that older adults really are not afraid of dying. I think they look at death as a welcome event. And I think what they're more afraid of is what's going to happen to them between now and the time that they die. And so they have these questions about what's going to happen to me? Am I going to be in pain? Am I going to suffer? Am I going to be a burden to my family? Am I going to bankrupt my family with my care at the end of life? And so these are the issues that they become very concerned about. I also notice as I've worked with people over the years that they expect to have this perfect death. In other words, they're going to just go to sleep one night and not wake up again, or they're going to have the big one, whether that's a stroke or a heart attack, and that'll be it, lights out. But what we also know now is that medical science, in all of its sophistication, is allowing us to live many more healthy years, but it's also condemning us in many ways to live many more unhealthy years. And that's the issue that we need to really come to grips with as we work with our patients. You know, I do a lot of work in the subacute setting, as I know you do, Don. And as I go in to do an evaluation, my first order of business is to go through the chart in great detail, take a look at the H&P, really understand what the chronic disease processes are. And after I do that, I have a certain amount of understanding of what's going on. And sad to say, a lot of these folks have been in and out of the hospital multiple times. They're on long lists of medications, and after I go through that process, I come to the conclusion that they're in the final stages of their life. And then I go in and I talk to the patient and the family, and I am dumbfounded by their expectation. They're talking about having cures and being returned to a healthy baseline again, and I know that that's not going to happen. And so it's important for us, again, to be honest with folks, and when I tell them the facts, they look at me and they'll say, well, why didn't my doctor tell me this? Why didn't the specialist tell me that? And I think that we do them a great disservice when we don't allow them to have that information so they can develop accurate expectations.
Yeah, and that's a good point. I mean, the population you're looking at in subacute, where high comorbidities, hospitalizations, and all that, you are catching them, well, we are catching them at times when there may be disagreement, differences in expectations and all, whereas in the outpatient setting, when things are a lot more calm, it's so much easier. It is.
Yeah. Okay. Older adults definitely want to have these talks. I think sometimes we tiptoe around this subject, being fearful that we're going to upset them or the family. But what I notice is that older adults will often test us, and they'll make certain comments that are a little bit provocative, and what they do is they wait for us to make an entry into that discussion. And so I think it's important for us to pick up on that and engage them in that talk when they let us know that they're ready to have it.
I agree. I will tell you, in the last year, I can think of just 2 seniors that seem caught off guard by this. The seniors know the score. They want to have the discussions. It's the children that...
Exactly. And what I think is important here is giving people information can be very empowering, and it gives them a sense of control. And I think certain evidence of this is if we take a look at the results of Oregon's assisted suicide law, very few people have actually taken advantage of that. And I think that what that has to do with is that once they were given that choice and given that piece of control, they felt much better. And so I think us being honest, open, and direct about this gives them a feeling of control and empowerment. Okay, when we want to have this discussion, I think we have to have it early and often. And we have to use our clinical judgment here as to when we might want to have a more intensive discussion about this. And the other point that I want to make here is that we need to involve a group of people. Families, systems are important here. We have friends, physicians, medical caregivers, home health care, clergy, attorneys, whatever. And those people need to be a part of the discussion as well, in my opinion.
Just want to comment on the frequency of these discussions. I would say in the outpatient setting, we ought to aim for a review once a year from a couple of different perspectives. One is that clinically, when you're looking at the number of changes, that seems like a good frequency. Secondly, in the annual wellness visit, we're expected to catch up on this then. And then finally, if you're doing the PQRI, in our practice, we happen to be focusing on advanced directives. Yearly, we want to look at that. So I think that's a good guideline. Whereas in the subacute setting, hospitalizations, long-term care, acute hospitals, yeah, you need a lot more frequently because of everything going on.
Exactly. One of the barriers to the discussion around death and dying issues has to do with grief. We know that older adults have suffered numerous losses over the course of their aging process. And the provider needs to be sensitive to the fact that we see people who are depressed versus people who are grieving. And I'd like to talk a little bit about grieving, because I think that providers oftentimes misdiagnose grief as depression, and then they will start antidepressant agents or maybe even adopt a more aggressive treatment stance, when in reality we need to understand that grief is a normal, natural event that we all experience at various times in our life, and it is a collection of intense emotional reactions such as anger, sadness, guilt, fear, and it is an emotional process that allows us to let go of our emotional attachments to people, places, and things. And so as I work with patients, what I try to do is normalize the grief process, help them to understand that this is to be expected and that they're not going crazy, and that we will be here every step of the way to help them with that process. Now, we need to understand also that there's two different kinds of grieving. The first one that we tend to think of more immediately is what we call normal survivor grief. This is the kind of a grief that occurs when we suddenly, without any particular warning, lose somebody who's important in our life. The type of grieving that we work with in our setting is what we might call anticipatory grieving. And this is the type of a grieving that can last over a period of 10 to 20 years in some instances, particularly when we're working with families who have loved ones with Alzheimer's disease or various kinds of dementia. And this is a type of a grieving that can get worse with time and can also turn into a full-blown clinical depression. I think the major thing that providers need to keep in mind here is that we have to keep people talking and expressing their feelings and let them know that that's okay. But sometimes we find that the anticipatory grieving process comes in waves. There will be times when it's stable and relatively not problematic, and then other times it flares up and can be quite difficult for the person to manage, which can get in the way of us entering into a conversation with them about end-of-life decisions. So let me go back to this issue of letting go. I think as a practitioner, my job is oftentimes to help people to let go. And one of the obstacles to letting go is a fear of what will happen to the loved ones that they're leaving behind. And family members oftentimes don't want to let the person go either, because they are an integral part of their life, and oftentimes much of their identity is tied up with their relationship with their loved one. So as I counsel family members one of the things I will help them to do is to express permission to the person who's in the process of dying to let go. Everything will be okay, we're going to manage without you, we don't want to see you suffer anymore. And in doing that, I find people then are able to let go and pass on.
Yeah, I would agree. And 9 times out of 10, these discussions lead to that kind of good resolution. But in the small minority of cases, we are dealing with our grieving through what we'll call the technological last rites. I mean, some of the stuff we see in intensive care units and subacute and whatever, where we think that this is causing unnecessary suffering and not necessarily reflecting the wishes of that patient, we have to recognize a lot of what we do in healthcare in this case is because the family's not able to let go and we're stuck.
Right, and we have to kind of let them do what they need to
Yeah.
do. I agree. As I begin to address some of these issues, I like to consider the issue of quantity of life versus quality of life. And I think most of us want quality versus quantity. And so I always have an ongoing discussion about what quality means to the particular patient at hand. And one of the ways that I open up that question when I'm assessing for depression is to just ask people, you know, do you ever feel that life is no longer worth living? And usually people will go ahead and start to talk to me about why they feel that life is no longer worth living. And after they make those expressions, then I will say, gee, you know, I really understand what you mean here. I think sometimes we get into this thought that if the treatment is available, then it is imperative that we use that treatment and we have to use that technology. And I think we have to remove ourselves from that idea because, as you know, I'm sure, that continuing to throw medicines or treatments at people do not necessarily result in any further quality of life and may in fact make it worse in some instances. And I think we need to, again, empower people to make that decision. It's their right. It's not our call. It's their call.
Correct. And we do have to take account for the family's preferences as well. And they're working together, and we do our best job to mediate that.
Right, exactly.
I would like to now focus on what I would consider very concise and effective way of dealing with these issues in the outpatient setting. This is a little different than what we've been talking about, Mark, where you're really going deep with the patient's family, staff, et cetera, in a subacute setting. Takes a lot of time, dealing with a lot of family issues, et cetera. This more is going to focus on looking at really the laundry list of things we have to do in primary care, whether it's covering vaccine status, discussing pros and cons of various screening tests, covering all the different medical issues we're dealing with, the medicines are on, et cetera. So let's throw advanced directives into that too. How do we do a fairly good job of covering that, knowing that it might get kicked down the road and no one covers it later on. So this is how I approach that. I explain to the patients, and often there's a family member there, that this is an issue we like to cover with all the seniors we care for. That kind of takes away their sense of, Dr. Murphy's bringing this up because he thinks I'm getting ready to check out. No, that's not the case at all. This is a routine thing that we cover. I explained to him I like to cover 3 different scenarios, and that when we, particularly the family members, know their preferences about those 3 scenarios, we pretty much know what to do no matter what type of illness might arise or how sick they might be. And I would say, again, in 95% of the cases, just with that introduction right there, the patients and families feel very comfortable going to the discussion. It's the small minority where they go, oh, wait a minute, we're not quite ready for this. So we go into it. These 3 scenarios are this, and this is how I explain to it. First one is a cardiac arrest. So I ask them to imagine living out in the community that they have sudden death. That is a cardiac arrest. Heart stops, they stop breathing, they drop down, they die. And the only thing that can turn that around is CPR, advanced cardiac life support. For the most part, patients and their families understand what this is. In those unusual circumstances where they don't, I give them a little more description of that. I also tell them what the prognosis is. If it's a relatively young senior with no comorbidities, the chance of them actually surviving to get to the emergency room is 1 out of 20. I let them know that. If, on the other hand, it's an older, frailer senior with multiple comorbidities, it's going to be closer to 1 out of 50, maybe even 1 out of 100. So I give them a pretty good estimation of their prognosis should they have a cardiac arrest. Then I ask them, would they want to have this? And the vast, I'd say the majority of seniors, roughly 80%, will say, yes, I would want to. Okay, no problem. We don't need to proceed more with the DNR order. But for those 20% that say, no, I don't want that, I then ask, how strongly do you feel about this? Half of those will say, I feel very strongly about this. And I go on then to explain to them that no matter what we've discussed in the exam room, no matter what they've talked with their family about, whatever they have written down, it does not matter. If they have a cardiac arrest and they're living in the community, the paramedics will show up and start CPR. The only way that that won't happen is that if they have a do not resuscitate bracelet or necklace. I explain that that's needed to assure that CPR is not initiated, and then if need be, explain how they can get those things. Sometimes the patients will say, well, I don't want to wear extra jewelry. And I say, well, that's okay. You really don't need to, in the sense that if you have CPR, you're not going to feel it, it's not going to work, and you're okay. I just kind of give them that reassurance. There will be some that are still ambivalent. They don't feel real strongly about this, and then I tease out further whether or not they should have a DNR order, whether they should get a DNR bracelet or not. The second scenario is I ask them to imagine that they get real short of breath, they're taken to an emergency room, the doctors there find that they have a real bad pneumonia, and that they would need to be on a breathing machine, a mechanical ventilator, in the intensive care unit, on IV antibiotics, whatever, for at least a couple of days to get better. And in this case, I emphasize that the likelihood of them recovering is much better. Unlike with CPR, in this case, it's at least 50-50. And so I ask, would you want this? The large majority say, yes, I would want this. And the very small minority that would say, no, I would not want this, I then explain that although we in the healthcare profession will respect those wishes, what's real tough is that if they go to the emergency room, they're at death's door and their family members are with them, and they expect the family members to readily accept that we're going to treat with morphine. That's a hard one to swallow. The family members need to be on board with that. In that case, they need to have further discussions to make sure that family members really do appreciate that. By the way, if they do say no to short-term mechanical ventilation, I then really do encourage them to get the do not resuscitate bracelet. Now, in that second scenario, I then ask, okay, imagine 2 weeks down the road, you're not getting better. Everything's going to pieces, you have tubes everywhere, your organ systems are failing. You get to a point where the prognosis is terrible. Would you want to keep continuing? And almost without exception, they say, no thank you, please pull back. So in summarizing the advanced directives, I put mechanical ventilation. Okay, short term, not long term. I don't need to get more specific about that, about timing. These things will play out in the ICU. The third scenario is I imagine them to look ahead 10, 15 years, imagine that they have an advanced dementia, they've gotten to the point where they no longer recognize anyone, they cannot speak, and now the issue that comes up is that they're having difficulty swallowing. Would you want to have a feeding tube placed through your abdomen? I cannot even get that question out before they're telling me absolutely not. They just do not want to have this. It's the rare patient who, based on his or her expectations about their faith tradition, might say yes to this, but it's really the vast majority that say no. And so in my advanced directives, it's pretty simple. CPR, what they think, mechanical ventilation, summarize, tube feeding, almost without exception, put no, they would not want that. And I just find that this profile here really helps give us guidance no matter what might come up down the road. Let's focus now on documenting the advanced directives. I want to emphasize, first of all, this does not have to be complicated. It can be as simple as something written on a piece of paper. If people want to take it and have it discussed with the lawyer and spell out, that's fine too. But it can be very simple as long as we have a good summary of that. Hiding it away doesn't help a lot, we know that. The key thing though is, in my opinion, it's not so much the paper documentation as it is making sure the caregivers and the families have had the discussion and people understand. That's what's going to matter down the road when things get difficult. It is important to designate a durable medical power of attorney. Mark, I know you've advocated that there be one, and we would too, but in some cases I would say as long as there's several different children, if they're on the same page, that's okay. But otherwise, yeah, having one person that we can go to is important.
Yeah, and typically I like to see the family identify somebody who's the leader or who's a consensus builder who can kind of bring the various people together. That's the key. It's when we get into these stalemates where it's everyone's digging in their heels and therefore we get no decision made. That's a problem, I think.
Let's talk a little bit about the specific tools. The living will, I don't find that helpful because it talks about a condition that rarely comes up. So if people tell me, oh, I've taken care of that, I have a living will, I push it and ask them, okay, let's go into some more specifics here. There are other tools that are very thorough. For example, the 5 wishes. I mean, if patients and families have the time and really want to dig deep, this is an excellent one to do that for. There's a new one out called the Most Form that many facilities and individual practices are using that are very helpful. It's a 2-page summary that I think really captures key things. And then, as I mentioned, if you just want to summarize, in the case I talked about before, the 3 different scenarios, that works too. So different people have different ways of doing it. The exact actual form doesn't work, but if people are so inclined to go deeper using these tools, great, they should.
Let's talk a little bit about hospice. I think for me it's incumbent upon the provider to have some basic knowledge about what hospice is, because there's a lot of misconceptions about hospice out there. A lot of times people think this is just where people go to die. You know, I've had the privilege of working with hospice since it was brought to Denver 30-some years ago. And as obviously we know that there's 2 different kinds of hospice. The first kind is the facility-based kind of a hospice program, and then the second one is the home-based hospice program. And both have their uses and appropriateness. I think that the saddest thing that I witness on a regular basis is people availing themselves of hospice much too late. They go in at the 11th hour and they die, you know, fairly quickly, and I just find that that's sad, because the family could have benefited from the added support and pain management for months and months and months, and therefore it would have been a much more quality experience for all involved.
Yeah, and you and I have both heard many times, gee, why didn't we know about this earlier? Yeah.
Yep, exactly.
I'd like to emphasize now that clinicians can get paid fairly for the work they do when they are spending time counseling the patients. And this applies to whether you're talking about advanced directives, as we focus on today, or whether you're talking about vaccines, screening, specific disease states and medication use, whatever it might be. When we spend greater than 50% of our time in the face-to-face encounter, in the outpatient setting, home visits, assisted living visits, when we spend greater than 50% time, we can bill for that based on time. And as we've noted today, when you look at the time we spend on advanced directives, these other issues, it does add up. And so we would encourage you to know about billing based on time so that you are able to capture the work you do. If you don't know the details of this, we would direct you to the MESA website on the archived webinars. In one of those, we go into much detail about how to bill based on time, and we would encourage you to use that. It is a good way of making sure that you cover these important discussions such as advanced directives with your patients and their families.